We're going to introduce our chair of the WFNS Spine Committee, Mehmet Zileli. He's going to be talking about philosophy of minimally invasive spine surgery. I think that today's session has been extraordinary. We have seen various aspects of it, and I think to wrap it up with the philosophy would be a great talk. Thank you, Mehmet.
I thank all of you for very nice talks and all the participants sharing time with us. Actually, this philosophy talk will make some comments on minimally invasive surgeries. This is my conclusion slide. The minimally invasive surgeries have advantages: short hospital stay, quick return to work, cosmetically better. Patients demand it more than surgeons, and the less infection rate. I think in your countries, the patients come to you, are you making surgeries in a closed manner? They tell this, they ask this. However, they have significant disadvantages. Long learning curve, we need special training for them. Special instruments and equipments, the basic equipment costs are very high. Tactile sensation and biplanar imaging is something lacking our feeling of the structures. Complications may be hard to treat. Safety can be a challenge, and they cause more radiation to surgeon. We don't want to get too much radiations, and outcomes are similar to traditional surgery. They are not much different outcomes than traditional surgeries. So indications are same with conventional surgery: no damage or less damage to surrounding tissue, and less infection is the main message of minimally invasive spine surgery. There are mainly three kinds of minimally invasive spine surgeries. One is the image-guided percutaneous technique, then the endoscopic techniques, and the mini-open techniques. You have heard all of them in this small symposia. Probably the most efficient and most minimally invasive surgery is the vertebral body support augmentation with vertebroplasty or balloon vertebroplasty. I don't want to use the kyphoplasty term, but balloon vertebroplasty is a very minimally invasive technique. If you look at the indications, you have heard about the MIS decompressions, MIS fusions, MIS deformity correction, and I will tell you some comments on that. Tube-guided surgery is very popular. Actually, it was first introduced by Foley and Smith in 1996. Then they were doing that with a key wire introduction and then tube insertions, and then placing dilators, and around the dilators a tube has a role for retraction. Then you can continue your work with using endoscope or microscope. Even Dr. Fester has said that he was doing, at the beginning, he was doing many surgeries under the loops. Currently, there are in the market metric system from Medtronic, EasyGo from Storz, and Destandu again from Storz. There are also local companies producing those tubes. Table-mounted fixator is a big good part of it. So then you can fix the tube to your table. So then, according to the Casper retractor in the lumbar spine, you can be more free to get good angulations to the target. You can even work from one side and make both sides decompression, like lumbar spine stenosis, unilateral approach, bilateral decompressions. These are some pictures. You can even use that in the paramedian endoscopic surgery for far lateral disc herniations. You can make it for the posterior microforaminotomies, like you can see here, one case. But full endoscopy is quite different than tube-guided surgery. With tube-guided surgery, you can use your conventional instruments, but with full endoscopy, you must switch to work under water irrigation system, and all your instruments must change. The tube, your tube diameter is about 5 to 7 millimeters, depending on the systems. There are mainly two approaches. One is the transforaminal approach, which was introduced first by Amin. Since he's an orthopedic spine surgeon, he has used the knee arthroscope for this purpose, and arthroscopic discectomy term he has used. The interlaminar approach for disc herniation and stenosis was first introduced by Dr. Ruten from Germany. It's quite much later than this. But transforaminal endoscopy can be indicated in approximately 20% of the patients. You can reach up to 40% if you are very experienced. And L5S1 is difficult. You cannot, because of the iliac crest, you cannot approach there easily. Interlaminar endoscopy can be indicated in 60% or more. Even all these surgeries you can make, except far laterals, you can make with interlaminar. So these two systems, Foley and Smith's tube-guided surgery, or Ruten's interlaminar full endoscopic system, are comparable systems. In this one, if you start your full endoscopy with interlaminar, you can have more risk, like dural injury or root injury. So then many surgeons recommend to start it with the transforaminal endoscopic techniques. If you want to go up, you need to use some drills, like you see here. These are specially designed drills, and you must add to your cost these drill bits. Actually, another expense comes from the drills. Disadvantages of interlaminar endoscopy is stenosis. Drilling is harder. Learning curve is quite steep, very long. Baseline instruments are expensive. Tube-guided discectomy can be applied in all forms, and it's easier to learn for a surgeon who are familiar with the micro surgery. Baseline equipments are cheaper, and the indications are quite larger in comparison to the transforaminal endoscopy. Salman has nicely described MIS fusion techniques. Pedicle screw fixation. The main advantage is that the muscle injury is less than open surgeries, because in the open surgery you must retract all the muscles, and then you are probably causing a significant muscle damage here. But with the minimally invasive MIS screw fixation, you don't. You dilate the muscles and then you work like this. But the AP and lateral fluoro is necessary. and navigation systems may be helpful, but at least at the beginning, you need to get more X-rays. Another problem is in long segments, placing the rod is not very easy, especially for multiple level fixations. That sextant systems, which was described by Kevin Foley, who is also the introducer of the tube-guided surgery, has been developed to adopt to the multi-level fixations. Yes, smaller incisions, less muscle retraction, less blood loss, reduced post-op pain, and shorter hospital stay. But the disadvantages, potentially longer operation times, longer learning curve, more radiation for surgery. You can also use MIS TLIF or ALIF surgeries. I will not mention them too much, but I want to mention one more surgery, XLIF, lateral approach to the spine. It has been popularized by Dr. Pimenta from Brazil in 2003. It is a nice surgery because you don't interfere with the great arteries and veins. However, if you go through the psoas muscle, you can injure the lumbosacral plexus, and the EMG monitoring is very necessary. Yes, you can even, with this technique, you can even correct some deformities because the cages you use here are very robust, the largest cage ever for lumbar spine you can use. After a while, the experience has increased, and at least for L4-5 level, it's not very feasible, and the injury to the genitofemoral nerve and the femoral nerve itself are quite often, and the people may have more and more some numbness and dysesthesia on the ventral part of the femur. So then many surgeons have left L4-5 level and need EMG monitoring and need special retractors to do that if you want to do with an with a minimally invasive technique. And we must call it, instead of XLIF technique, we must call it transpsoatic approach. So recently there is another trend that oblique lateral lumbar fusion, just in front of the psoas muscle, you can insert a cage and make a fusion. There are also some other fixations like transfacet fixation, translaminar facet fixations. This is one of the cases. But in between, the so-called axial lift surgery has been introduced to make a fusion for L5S1 level. Actually, transpsoatic approach is not applicable for L5S1 level, as you know. It's very caudally placed. You cannot enter there. But although it was very popular probably 10 years before, now it lost its popularity because of a very high non-union rate, because you cannot remove the disc from here, and then you cannot place good enough bone graft here. Secondly, there have been reports of bowel injury, rectal injury, which may be very morbid and mortal for patients. And additional fixation is necessary because standalone usage is not a strong fixation. So nowadays it lost its popularity, and many surgeons have left it. MIS deformity correction can be done by anterior and posterior surgeries. In the past, we heard a lot about the thoracoscopic releases and instrumentation, but nowadays the indications have shrinked, and only in some children there are some from the convexity side some ligament applications and correction of the deformity by endoscopic thoracoscopic technique. Yes, mostly abandoned. In conclusion, we must stress here that infection rate after MIS surgeries are quite lower than other surgeries. This study says that in more than 1,300 patients, 10-fold less infection than open surgeries. It's quite impressive. In general, open surgery has more postoperative pain, longer hospital stay, cosmetically bad and tissue scar, but MIS surgeon need expensive setup, more X-rays for the surgeon, steep learning curve, and long-term benefits may be questioned. So if we are forcing ourselves for MIS surgeries, we are obeying mostly the patient demands, and they control our techniques. And this is my conclusion slide. I have mentioned that at the beginning. And as the last slide, I say indications are same with conventional surgeries. Outcomes probably same. There are some reports that in some MIS surgeries outcomes are better than open surgeries, but it's not very widely accepted yet. More radiation is one of the disadvantages. Thank you for listening. Please visit our website, WFNS/spine.org. This is most of our webinars are recorded, and you can approach them from this website. Thank you.
Thank you, Mehmet. I think brilliant talk, brilliant overview. I think you went through all the history and the advantage and the disadvantages of all the techniques that we have seen over the years. Well, I think as you say, I think it's patients' pressure that we're doing more of these. On top of it, there is no doubt that this is the future, because we know that infection as well as adjacent segment disease and pain and early return to work, all those are important. And on top of it, the medicines that's required post-operatively are much less compared to open surgeries. Onur, would you like to have any comment on this, please?
Zileli, thank you so much for this nice presentation. As you mentioned, minimal invasive, especially in deformity surgery, will be the future. And especially the hybrid systems, fusing the apex of the deformity and adding hybrid system at the bottom and at the distal parts, using the minimal invasive surgery will be the future. Thank you so much for all talkers. This was really a good symposium. Thank you, Salman.
Thank you, Mehmet. Any other questions, comments?
Enric, do you wish to make some comments?
No, I think that your presentation was great, because synthesize of the situation and the developing. The minimal invasive techniques are developing and really are the present and the future. And without a doubt, is day by day is improving, and all the surgeries are become better with the minimal invasive.
Jose, are you there?
Yes, of course. I think one of the most important issues about MIS in the last times are the number of papers talking about the cost benefit rate, and is absolutely better when it's indicated the MIS procedure. The cost benefit, especially in low and medium income countries, is very important. So, yes, could be a little bit with more cost at the beginning, but when you take in account all the whole evolution, the medicines, the rehab, etc., absolutely the MIS is cheaper than open procedures. Thank you.
Yeah.
Great talk.
Dr. Mohammed is with us from Bangladesh. Mohammed?
Yes.
Yeah.
Yes, I am.
Okay, please
Yes.
tell something about, make some comments about that.
Thank you, Mehmet Zileli. Actually, it is the second webinar program organized by WFNS Spine Committee and Neurospine Society of Bangladesh. Previously, with the topics of adult spinal deformity, we have done another webinar program. I want to thank Professor Mehmet Zileli, Chairman Spine Committee of WFNS, who has taken all the burdens for organizing in 2 days fantastic scientific program with renowned international faculties. Today's program is very much extraordinary. Mehmet Zileli and other speakers delivered a great talk. So I want to thank the speakers, Richard Kastler, San Kim, Enrique Osorio, Jose Seriano, and our old friend Salman Sharif. And also I want to thank Onur Yaman of Turkey. I think through this program, it makes up a great opportunity to learn the participant to upgrade and review their knowledge in spinal deformity and also in minimally invasive spine surgery. I want to request Professor Mehmet Zileli so that in the upcoming days, the WFNS Spine Committee will continue a big hand to us to organizing such scientific program in Bangladesh. Neurospine Society of Bangladesh is going to organize international program, Neurospine Conference in Dhaka in October 2021. I want to request Mehmet Zileli and WFNS Spine Committee and all other faculties to visit in Bangladesh in that time. Thank you, Mehmet. Thank you, our honorable speakers. Thank you all.
Thank you all. Actually, Rick Fester, I think he had an appointment. He's not connected now. Dr. Kim, do you wish to say something?
Yes, today WFNS Spine Committee minimal invasive spine surgery meeting is very nice, and this is very nice symposium for discussion about minimal invasive spine surgery. And today, I think that maybe today we discussed the field of minimally invasive spine surgery recently. Use the techniques, and maybe, and also maybe in the future I hope to make some symposium like this maybe in the future by the WFNS Spine Committee. Thank you so much.
Okay. Thank you. Thank you all the speakers. Thank you all the participants for being with us 2.5 hours. I want to close the session and say goodbye. Please stay safe at your homes and be away from COVID. Goodbye.
Okay. Okay. Happy New Year and be safe.
I think the same. Happy New
Year.
Yeah,
I wait for you in Colombia next year for the World Congress, please.
Okay.
Ram,
Goodbye.
bye-bye.
Bye-bye. Happy
you.
New Year.
Goodbye, Salman.
Happy New Year.
Bye-bye.
Happy New Year.
Mohammed.
Goodbye.
Happy New Year.
Happy New Year. Thank you, everyone. Thank you for accepting.